All right. Well, welcome everybody on at 8 p.m. On the East Coast in middle of the week. And we have a very, very interesting topic today. It's about obstetrics and COVID-19 and various aspects of it. I will keep my introduction short, even though I could have gone for the hour with the faculty we have. But I want to make sure I have enough time for them to, talk about the topics. So my co-moderator, Dr. Sheetal Gandotra, is an assistant program director for pulmonary and critical care at the University of Alabama, Birmingham, and she will be monitoring the chat with me and making sure that your questions get addressed as much as possible. Dr. John Folk here, he's a maternal fetal medicine specialist at SUNY Upstate Medical Center in Syracuse and Crouse Health. He's an associate professor for both OBGYN and medicine and has interests in high-risk pregnancies. I have Dr. Salma Shaker, who's from the University of Minnesota. She's obstetrical, OBGYN certified and critical care certified. So she's at the true center of this, and then has interest in emergency gynecology. I have Dr. Stephen Lapinsky coming up after Dr. Shaker, who's at Mount Sinai Hospital up in Canada, who's a professor of medicine and the director of the medical ICU. He has been an inspiration for me personally because of his interest in work in obstetrical critical care. And then last and most importantly, I have Dr. Rohan D'Souza, who's presenting a very, very interesting topic. He's going to be talking about the upcoming therapies and established therapies and how to employ them for pregnant patients in terms of COVID-19. He's also an assistant professor of OBGYN at the University of Toronto and a maternal fetal medicine specialist at the Mount Sinai Hospital. So while I take a breath, welcome all of you. Thank you for taking time out and doing this with us. And we'll get right to it. In a second, I just have a few things to share with you, with everybody. Besides these topics we'll be covering today, we usually record our presentations, so you'll be able to find this once it's done recording. These are the topics that we've covered at the ATS Critical Care Training Forum for COVID-19 in the past, very high-yield topics. So if you search for ATS COVID Forum or go to this link, which we can post in the chat box, you can access all the previous webinars and even the slides from the faculty. We are planning the following topics coming up. And if you have any ideas, we would love to hear them, and we'll get the experts from around the world to bring them to this forum and share that sort of expertise with you. And last and most, this part is very critical for us as organizers to, improve our offerings. So please scan this with your phones, and we'll even share the link in the chat. And please leave your comments for the faculty as well as for us with your ideas. Finally, this is the fantastic team that brings this critical care training forum to you every week, and we're very thankful for our resident as well as ADS staff for the fantastic work they've done in actually making sure that we have a durable, offering every week, covering all aspects of COVID. So with that, Dr. Folk, you're all set to take it away.
All right, then. Good evening, everyone. Let me get my screen set up here for everyone. All right, and just for a point of clarification for everyone, I did my residency in obstetrics and gynecology, but I did my fellowship in adult medicine and critical care at Wayne State in Detroit, and then joined the Division of Maternal Fetal Medicine at SUNY Upstate Medical University, and I'm also part of the Division of Pulmonary and Critical Care, talking about obstetrical matters with their critical care fellows. I had disclosures, if there was a way to make money doing this, I hope I would have found it by now. I'm still getting, the usual amount of compensation I normally would get. My topic is, as the previous slide said, impact on pregnancy outcomes and vertical transmission specifically. Essentially, some of the things that we're finding out, and the great part about doing a presentation in this topic is that this is the first time I've ever been asked to speak where all of my references have come from 2020. And despite the fact that they're that they're all this year, it's amazing how quickly a lot of these references become outdated and incorrect in their impression. But what we know so far with this disorder is that it does tend to have the same kind of spectrum as it would in any patient who would contract COVID-19, with most of the patients either asymptomatic to mild pneumonia, with a roughly a quarter having severe disease and a minority having critical disease and a few case fatalities as well. We are starting to figure out, though, early on, the maternal fetal medicine literature did talk about how this disease was actually no worse than we were experiencing in the general population from the early series that were coming out from Wuhan, China, and then from Europe, and then later from New York and Seattle. But now we're starting to find out that when folks are really digging into it and looking at the data long term, that the case severity seems to be a bit higher among pregnant women, a bit higher incidence of critical disease, but the case fatality rate appears to be remaining stable, which is good news. The relative risk, I mean, most of this data is, again, small series and case reports from individual institutions. So far, the feeling tends to be there does not appear to be an increase in acquiring SARS-CoV-2 infection. There appears to be a moderate increase in severe infection compared to the non-pregnant population. Most of the obstetrical patients do, fortunately, when they contract this disorder, make a good recovery. There appears to be a higher incidence of ICU admission, a higher incidence of needing mechanical ventilation. And all of this remains true when an adjusted relative risk is undertaken that accounts for age, medical conditions, underlying medical conditions, race, and ethnicity. We do see more disease, as we do in the general population, among African American and Latinx pregnant women, disproportionately affected more than others. Underlying medical conditions are important. There is an increased hospitalization among pregnant women, likely related to admission for OB indications, as well as for issues related to the COVID-19 itself. One of the things that's very important is that when an obstetrical patient is diagnosed with COVID-19, it is essential that her primary OB care providers follow her very carefully to make sure that she is following a more benign course, and to get her evaluated as soon as possible when the disease appears to be getting more severe and perhaps moving into a critical situation. Areas that are at increased risk, we know this from looking at Centers for Disease Control data over a long period of time. The conditions on the left tend to be the ones that are most commonly associated with pregnancy and a higher incidence of severe disease, with cancer, chronic kidney disease, immunocompromise, obesity, type 2 diabetes, these kinds of things. Other conditions have not yet reached the level of significance of the increased risk, but a lot of them would look familiar to anyone who does high-risk obstetrics, and includes asthma, cerebral vascular disease, hypertension, liver disease, pregnancy itself, smoking, thalassemia, and type 1 diabetes. A systematic review and meta-analysis of 19 studies that include 79 pregnant women and 41 pregnancies is actually in press, but yet available. In my references at the end of the presentation, I have this particular study listed. It involves pregnancies that involve all of the coronavirus-based illnesses and the experience that we have with pregnancy, including COVID-19, MERS, and SARS. Pneumonia, fever, and cough tend to be the most important findings. Dyspnea is also very important. in all of these patients. Here we have a relative distribution of the incidence of complications, obstetrical complications related to women who develop COVID-19 infection during pregnancy. Important outcome for COVID-19 in particular is preterm delivery, which actually is much more prevalent than it would be in the usual general obstetrical population, as you can see over on the far right. Miscarriage, preterm delivery, preterm premature rupture of membranes, and preeclampsia seem to be more common among women who develop COVID-19 infection while they are pregnant, particularly in the second to third trimesters. Fetal growth restriction does not appear to be greatly increased. Cesarean delivery is far more common. Perinatal death or loss of a fetus or a newborn is more common. Admission to the neonatal intensive care unit is far more common. But this particular series did not identify any cases that would strongly suggest that vertical transmission is possible. Looking at the studies regarding vertical transmission, there are a great number of studies that do not demonstrate any association with women having COVID-19 infection and then delivering fetuses who are infected at the time of their birth. I have a large number of studies here. The references are available at the end of the presentation. There are some studies that would suggest vertical transmission. Perhaps the study with the best evidence is a single case study that follows a patient from intensive care admission for severe COVID-19 disease requiring intubation and mechanical ventilation, who went on to have delivery. The fetus was then immediately isolated and was immediately evaluated and was found to have virus on neonatal nasopharyngeal cultures. It's probably the closest one that I can think of that comes to a strong association with potential vertical transmission. In the series that report the possibility of vertical transmission, these cases tend to be mostly associated with severe disease in the mom. So in other words, moms that have very bad disease, critically ill, severe disease, tend to be the ones that are more likely to have a fetal, neonatal situation that suggests vertical transmission. So far, among the babies that were born to moms that had the severe disease, neonatal respiratory distress syndrome in preterm infants was associated. So it really is very hard to distinguish whether this is lung disease that's related to the pneumonitis associated with a viral infection, or is it just simply neonatal transient tachypnea or neonatal respiratory distress syndrome that would go along with prematurity. So recommendations that come from the articles that I have looked at indicate that prevention is right now our best strategy for preventing complications related to COVID-19, related to pregnancy. And these are all the things that we are all busy encouraging ourselves and our patients to do. Physical distancing, hand hygiene, disinfecting surfaces, and wearing a mask or other appropriate face covering. Pregnant women are advised at this point to reduce their exposure to to children less than 10 years of age, which certainly is a great challenge to ask someone who's expecting, who likely already has small children or is spending time with small children. The Centers for Disease Control of the United States has made a recommendation in-person playtime for pregnant women that involve children of other households should be limited. They should play outside. They should wear masks. They should apply all the social distancing strategies I already mentioned. Evolving recommendations for pregnant women that have to do with occupational guidance and restrictions, particularly among pregnant women who are healthcare workers, is still evolving. The comorbidities and individual work situation, in other words, you take each individual patient's situation into consideration, and that should be the main guide for what recommendations we make for women who are pregnant, who should specifically consider limiting their work activities and the like. And another thing we were just talking about, I was rounding on the maternal fetal medicine service today at my hospital, and I ran about a 25% rate of being able to get my pregnant women who are admitted to the hospital for long-term obstetrical complications, nothing related to respiratory disease. Got about 25% of them that were willing to take an influenza vaccine after I explained to them that the combination of an influenza on top of a COVID-19 pneumonia probably would go very badly during pregnancy. Workup, I mean, a lot of folks will, coming after me will probably talk about with suspected infection, workup according to current policies and procedures. With known infection, careful monitoring, as I mentioned before, for progression to severe disease. And because there is a lack of evidence, decisions regarding optimal time for delivery or mode of delivery, vaginal versus cesarean, are based on obstetrical considerations alone. In other words, you deliver the baby because obstetrically that is what's needed at that time. There does not appear to be any evidence to date that cesarean delivery would reduce vertical transmission as it does for some other viral infections such as HIV. And here are all the references that I did look at for this discussion. And there's some general review of information related to what we learned from the, those of us that are a little older, remember the H1N1 flu pandemic in 2009, and some normal physiology of pregnancy that may suggest why pregnant women are at increased risk for pulmonary compromise while pregnant compared to women who are age matched and medical condition matched for lung disease related to this infection. Well, thank you. That's all I have to say.
So next up, we have Dr. Shaker. Dr. Shaker, whenever you're ready. In the meanwhile, while you're pulling up slides, Dr. Fork, the question for you was that there's data in general population showing that patients with hypertension and diabetes are at higher risk for, acquiring and for severe disease. Any inkling yet whether gestational diabetes or pregnancy-induced hypertension confers similar risk?
Well, that's not very clear right at the moment. And as you can imagine, the way these data emerge is the more people that get sick, the more likely we are able to have enough population data to actually calculate a p-value related to these kinds of things. My impression would be that I would be more leery of a gestational diabetic or a gestational hypertensive compared to someone of the same age who does not have these conditions. But we also got to, I think that some of the issues that are going on that I find interesting is that, if you look at something that also involves an endothelial dysfunction process that leads to endothelial injury, like preeclampsia, complications are more common among people who have had longer standing endothelial stress. So chronic hypertensives, type 2, type 1 diabetics, more likely to have preeclampsia spectrum disorders. So I think to a certain extent, if the COVID-19, which appears at some point in its transition from mild to severe disease, also involves an endothelial injury, I think that perhaps those patients that don't have the long-standing endothelial dysfunction are likely to get less sick. But, I still would say, like in my clinical practice, I would certainly watch them more than someone who doesn't have those conditions.
That's fair. Dr. Shaker, you're free to share your screen and take off.
All right, good evening. Thanks for joining. So I'm going to talk a little bit about specifically obstetric management of patients during COVID-19, and hopefully trying to cover patients with COVID-19 and then how we look at our OB patients when we're considering COVID-19 as a possible diagnosis. So I'm going to break it down into things like prenatal care, triage visits, inpatient management, and postpartum management, trying to kind of include the obstetric viewpoints. So ultimately, our goals with prenatal care include early and continued risk assessments for patients throughout their pregnancies. Prenatal care provides us an opportunity to give general health promotion and advice, and then medical and psychological interventions and follow-up. Traditionally, prenatal care is divided into 14 visits, with most visits towards the end of the pregnancy. And then there are alternative schedules that have been evaluated with fewer visits. And we don't find that we don't find a big difference between maternal death, hypertensive disorders in pregnancy, preterm birth, and small for gestational age infants in patients who underwent fewer visits and patients who underwent the full 14 visits. We do know that patient satisfaction is decreased, but this gives us a little bit more kind of support when we're asking patients to decrease their frequency of visits if certain situations like a COVID diagnosis comes up. Recently, there was a study that came out of New York looking at around 3,000 deliveries, and they didn't find a significant association between the number of in-person healthcare visits and COVID-19 infection, which supports the current Society for Maternal Fetal Medicine guidelines that we should continue our current standards for prenatal care. But trying to consolidate visits like an in-clinic check-in and ultrasound being scheduled at the same time and place to help minimize staffing and the exposure of healthcare workers to patients that may be asymptomatic and positive, and then minimizing the patient's exposures to each other. And then scheduling things like ultrasounds, which can be recommended pretty frequently in pregnancy, changing that scheduling to try to get the most out of each visit. Things like early cell-free fetal DNA testing rather than early ultrasounds with nuchal translucency evaluation, or using a once-weekly ultrasound rather than twice weekly assessments of fetal heart rate monitoring in order to, again, limit in-person visits when possible. Triage visits, specifically for pregnant patients should come in for evaluation during the typical kind of a recommended obstetric indications. So if there are concerns about early delivery or preterm rupture of membranes or decreased fetal movement, a patient, whether COVID positive or not, should come into the hospital for evaluation. And the increased risk of things like preterm delivery really that are seen in COVID-19 really support this, that patients should not be asked to stay at home if they're having concerning symptoms for or obstetric indications to come in. Some of the symptoms that we're all looking out for in ourselves and asking our patients to look out for, including things like shortness of breath, muscle and body aches, vomiting and diarrhea. Some of these can present in pregnancy as normal parts of pregnancy or as normal complications of pregnancy. And so we really need to look at the big picture and kind of combination of these symptoms and also have a really low threshold for testing our pregnant patients. Sorry for this busy slide, but specifically looking at antepartum management. So any OB patient that's admitted, whether for delivery in the next few days or admitted for an obstetric indication that doesn't include delivery right away, or if they're admitted for COVID symptoms. The typical obstetric indications stand for admissions. And then specifically with COVID, we're looking at things like moderate to severe disease. If they're not maintaining an SpO2 of greater than 95% on room air, having increased respiratory rate, cyanosis, pleuritic chest pain, all of these things should push you to admit a patient early. And then things like chronic comorbid conditions, uncontrolled hypertension, renal disease, uncontrolled diabetes, and cardiopulmonary disease. The things that not only might have negative pregnancy outcomes if they're uncontrolled, but also complicate the recovery from a systemic severe disease like COVID, would prompt you to admit the patient to the hospital sooner than you might for a non-pregnant individual. And then looking at things like fevers and trying to rule out or evaluate for cytokine storm syndrome. Now, kind of looking at COVID patients and obstetric patients, I think something that we have to reinforce is that we should be using a multidisciplinary approach. So there are very few obstetricians who are going to be comfortable diagnosing and managing COVID-19. And very few internal medicine physicians who would be comfortable managing obstetric patients. So using that team approach in order to best get care for both the maternal side of the patient and the pregnancy. Universal screening should be utilized for every labor and delivery. So not only asking the patient, but also asking whatever support person might be coming in about fevers, chills, and the symptoms that we look for COVID. The consideration for universal testing is there. There isn't a current recommendation for universal testing from the CDC or from the Society of Maternal Fetal Medicine. And when we look at New York, when universal testing was done, when there were around 80,000 cases in the population, they found that 14% of pregnant patients were positive. In LA, when it was a little less than 10,000 positive cases in the population, and universal testing was done, they found 0 cases at some of their facilities. So you really have to look at not only the kind of growth of how many more cases we're getting, but also how many cases are prevalent in the population that the hospital is before deciding if universal testing is going to be the plan. So that should also be individualized. Another part of the kind of antepartum patient is looking at steroids. So we always think of steroids for fetal lung maturity in the setting of pregnancy. And we know that patients with COVID-19 are at higher risk for preterm delivery. Early on in this pandemic, there was a lot of concern about giving antenatal steroids to patients with the concern about steroid causing that viral low to be prolonged. But with the results of the recovery trial, or the preliminary information that we have, the current recommendation from the American College of Obstetrics and Gynecology is to administer 6 milligrams of dexamethasone intramuscularly every 12 hours for 4 doses for inpatients who meet criteria from the recovery standpoint, from the recovery trial standpoint. And then following up the rest of those doses, the rest of those 8 days, with 32 milligrams of methylprednisolone IV daily. Methylprednisolone won't cross the placenta, so you don't get the high steroid effect on the fetus, but you still get the benefit of those first 48 hours of steroids for fetal lung maturity. And then magnesium is often used for neuroprotection in pregnancies that are less than 32 weeks gestation, but can cause maternal respiratory depression. So if you have a patient admitted with COVID who does have respiratory symptoms, you really need to weigh the risks and benefits there, and the concern for imminent delivery. Anticoagulation, I think, is a popular question that is, I don't think we have a clear answer for. The current recommendations from the Society for Maternal Fetal Medicine recommend prophylactic anticoagulation for any patient that's admitted, unless they're diagnosed with an active clot, and then therapeutic anticoagulation recommended to use heparin, so that you can have the ease of giving an antidote and reversing it if something like a preterm delivery is impending. There are hospitals that use the higher intensity dosing that is not quite therapeutic for COVID positive patients. And there are some recommendations at certain facilities that have come out using D-dimer cutoffs to help decide if you're going to give a higher intensity anticoagulation dose. At this point, we don't have data to say that we would recommend that over using prophylactic dosing, but it should be site specific. So if there's internal data that the hospital has, then using that to help guide your care. And then fetal evaluation. Oftentimes when a patient is admitted to the hospital with a non-obstetric indication, we recommend daily fetal heart rate monitoring. That should really be discussed with the maternal fetal medicine physicians as well, to help decide what's the most appropriate type of evaluation and how frequent that evaluation should happen. The next question, of course, is timing of delivery. So as Dr. Wolf said, delivery really should be for obstetric indications, and that's kind of the theme through this, is that obstetric indications still should kind of drive our care of obstetric patients. You should consider expectant management until 14 days positive, or 7 days after the start of symptoms if they've been symptom free for 3 days, especially towards the end of pregnancy, and if there isn't another indication for delivery. So things like elective inductions of labor, if those can be delayed, then that would be ideal if someone has had a positive test. Intrapartum management, so looking specifically from an OB standpoint. So these are things that we're going to be worried about during delivery. So things like internal monitoring, using amniotomy or operative vaginal deliveries. Currently, the vertical transmission data we have supports the use of any of our typical interventions for our obstetric patients. The American Society of Anesthesiology, Obstetric Anesthesia and Perinatology recommends and encourages early epidurals to try to avoid the need for general anesthesia and emergent intubation if an emergent cesarean delivery were to be recommended. And then finally, nitrous oxide in patients with known COVID is recommended against, and it's actually many facilities have taken nitrous oxide away as an option, knowing the risk of asymptomatic positive patients, because it is by definition an aerosolizing procedure. And the mode of delivery. So, again, obstetric indications. So there have been some case reports of vaginal deliveries in patients who are intubated with COVID-19, and even inductions of labor for those patients. If acute respiratory distress alone is not necessarily an indication for delivery, if a patient is 34 weeks or more, and you're anticipating that the maternal respiratory decompensation is worsening or continuing, then that's usually an easier decision to deliver, because we know that fetal outcomes are generally good after 34 weeks. Between 24 to 34 weeks, then you're really weighing the maternal risk for decompensation and the fetal risks with prematurity. There isn't any current data to say that evacuating the uterus will for sure improve respiratory status. So this needs to be an individualized decision, and ideally a decision that's made with a team of high-risk obstetrics, intensive care, and the patient's family. Ultimately, if someone is in severe respiratory distress and the plan is to deliver, to try to aid in the maternal care, then expediting delivery via cesarean section is relatively common. Almost 90% of patients who are critically ill and are requiring mechanical ventilation ultimately are delivered by cesarean section. And then looking specifically at postpartum management, so the management of patients who test positive during their intrapartum course or during their hospitalization or develop symptoms and therefore need to be tested, the goal is to expedite that maternal testing. There stands a recommendation of separation by 2 weeks in a patient who's COVID positive, but breastfeeding and pumping is still recommended. NSAIDs can be used for pain in the postpartum period, given the increased risk of opioids. And then discharging home should be expedited whenever possible. But again, we have to meet our safety criteria based on obstetrics and our respiratory standards. Ultimately, multidisciplinary care is key. So any obstetric patient with COVID-19 needs a group to help treat patients, specifically determining delivery, administering medication, and then deciding on fetal monitoring. And then I think the last thing that, when we think of obstetrics, we think of our viable pregnancies. We think of our patients that are, I should think of my patients that are 24 weeks and beyond. But in pre-viable pregnancies, there should be almost no limitation on maternal care, because we know that if women don't do well in early pregnancy, we know that there's higher risk to problems with the fetus. So that again can be a hard thing to consider for someone who doesn't do obstetrics, who doesn't do high risk obstetrics, which just supports the need for a multidisciplinary team. All right. Any questions? Thanks, you guys.
Thanks so much, Dr. Shaker. I was wondering if you could elaborate on whether there have been any changes to, usual recommendations for skin to skin and things like that post, delivery. And then next up, once you've answered that, will be Dr. Stephen Lapinsky discussing management of pregnant patients that are critically ill with COVID-19. So Dr. Lapinsky, while we answer that question, if you want to go ahead and get your slides set up. Thank you.
So the initial recommendations were to limit things like skin to skin and delayed cord clamping in patients that were under suspicion or under investigation. The most recent kind of information, knowing that we don't have a lot of information to support high transmission, is that things like delayed cord clamping can be okay. But skin to skin is still generally limited, and any kind of interaction of the mom with the neonate, it's recommended to have the typical, hand washing, and even with breastfeeding, using things like hygiene of the breast prior to initiating that to try to limit exposure to the fetus.
Great, thank you for that. Dr. Lapinsky, whenever you're ready. You're still muted, Dr. Lapinsky.
Thank you. I'm unmuted and my screen share is also disabled. If you can enable screen share for me. Thank you. Right, well, thank you. So I'm going to be talking about the ICU management of the COVID patient. And I'm fascinated to see how the previous two speakers from different areas of the continent and different specialties with a total lack of data have exactly the same suggestions and management as I have. So there's very little data. So what I'd like to talk about, this is mainly for the ICU and pulmonary and critical care people, is what are the risks to the fetus in a critically ill mother? Because this is always a big worry, although it really shouldn't be. A little bit about COVID critical illness in pregnancy, and then mechanical ventilation in pregnancy. So what are the risks to the fetus? I'm going to talk about hypoxia and hypercapnia. I mean, those are the basics of pulmonary and critical care. A little bit about radiology and drug therapy, but probably the biggest risk, as already alluded to, is premature delivery, but that's out of my area of expertise and left to the obstetricians. So hypoxia, delivery of oxygen to the fetus depends on oxygen saturation plus hemoglobin and blood flow. And this is blood flow to the uterus and placenta. There are a lot of guidelines suggesting keeping a saturation above 94% or 95% or even 97%, but it's likely that the major factor is this blood flow. The blood flow can vary quite dramatically and probably plays a far greater role than the oxygen saturation. Important for you intensivists to keep your patients in the left lateral position to allow venous return and keep the cardiac output up. It's also clear from recent literature that hyperoxygenation, giving too much oxygen, is bad for mother and fetus. Hyperoxygenation tends to cause generalized arterial vasoconstriction and a drop in cardiac output. And if anything, it may have an adverse effect on fetal oxygenation. So keep it somewhere in the middle. In terms of carbon dioxide, very little data, but low CO2, so overventilating decreases uterine blood flow, causes uterine vasoconstriction, and also causes fetal cerebral vasoconstriction, similar to what it does in the adult. So low carbon dioxide is bad for everyone. High CO2, really unclear. There are a few small studies, and moderate levels are probably reasonably well tolerated by the fetus. And there are case reports of asthmatic women with CO2s above 100 for an hour or two who ultimately, mother and fetus, have both done well. In terms of x-rays, another major concern of non-obstetricians in the ICU. So just briefly some numbers. So x-ray risks are that it can be carcinogenic, producing childhood leukemia, teratogenesis, and also affecting neurological development. And the amount of radiation required is in the range of greater than 50 to 100 milligrays. Often 100 to 200 milligrays are the numbers given. And when you look at it, a chest x-ray gives a fetus about 1/100th of a milligray. A chest CT scan, as high as 0.2 milligrays. Although if you do an abdominal pelvic CT, that can reach 50 milligrays, which might be reaching those levels of concern. But if the woman has a perforated bowel and you really need to know what's going on, it's a relatively small price to pay, weighing up the risks and benefits. So don't worry too much about x-rays in the ICU. In terms of drugs, inotropes are all potentially bad for uterine blood flow. The vasoconstrictors are going to reduce uterine flow. The vasodilators, such as dobutamine, are going to shift blood away from the uterine bed. So an alive mother is always better than a dead mother. So you would use your usual inotropes. You would use norepinephrine for hypotension. Obstetric anesthesia are now increasingly using phenylephrine to treat hypotension related to neuraxial anesthesia. And in my hospital, they're often doing prophylactic phenylephrine infusions to maintain the blood pressure. In terms of sedation and analgesia, very little data on what is best for the fetus. As with all patients in the ICU now, we try and minimize drugs, use as little as possible. often fentanyl with maybe a little bit of propofol. Neuromuscular blockers do cross the placenta to varying amounts depending on the actual drug, so the fetus may be paralyzed. So the most important aspect of this is, if delivery does happen suddenly, to warn the neonatologist who's going to be looking after the newborn, because the fetus may be very sedated and or paralyzed. Other drugs don't avoid anything that's necessary for the mother. Already covered is how dexamethasone and betamethasone do cross the placenta and are used for fetal lung maturity. The other steroids are hydrocortisone, prednisone, methylprednisolone, don't cross the placenta. So in terms of managing the patient in the ICU, this is my picture to again emphasize what has been discussed before, the multidisciplinary care. So it's the intensivist with the maternal fetal medicine specialist, the neonatologist commenting on the neonate, usually obstetric anesthesia, and often we would have multiple other subspecialists, rheumatology, hematology, infectious diseases, all involved in managing patients. So what data is there? I've just gone through a few of the systematic reviews. So amazing, it's been like 6 months and there are already 4 or 5 systematic reviews out. So this one, the most recently reported in American Journal of Obstetrics and Gynecology, 15 reports of pregnant women. They identified 85 cases with 11 deaths, which comes to a 13% case fatality rate, very high. But 7 of the deaths were from a single Iranian report. And if you exclude those, the overall death rate is 5.3%. Not too sure what to make of that systematic review. Then a review from New York, where they identified 462 pregnant women, of whom 70 were severe and 13 required ICU. The risk factors for ICU were Hispanic, obesity, sleep apnea, asthma, and 46% had no risk factors. 8 required mechanical ventilation, 7 vasopressors. The majority actually got hydroxychloroquine at that point. 2 of these patients died, giving an overall mortality of 0.5%. 7 were delivered while in the ICU. 5 were urgent cesarean section for respiratory decompensation, and we'll talk a little bit more about that later. Then this systematic review from the United Kingdom, 17 studies with 2,500 pregnant women, 7% required ICU, of whom 3.4 were intubated and 0.7% were put onto ECMO, with a 1% mortality rate. And they identified risk factors of comorbidity, I think using Charleston comorbidity, and an age greater than 35 years, which for obstetrics is getting quite old. So mechanical ventilator support in pregnancy. I'll start off talking about non-invasive ventilation. So we're all scared of non-invasive ventilation in COVID days because it's apparently a airborne medical procedure, but it can be done. In Italy, they used it quite extensively using the helmet. So the helmet does allow a relatively closed circuit with a filtered expiratory limb. So you can do that, and we are setting up for helmets for a possible second wave. And non-invasive has advantages of avoiding the difficult intubation, avoiding sedation. There is a concern about aspiration in the pregnant patient particularly, but it may be a potential option for short-term ventilatory support. Remember that endotracheal intubation in pregnancy is difficult. Failed intubations are 8 times more common than in the non-pregnant patient. This is related to anatomical changes, upper airway edema and friability, the risk of aspiration because of reduced lower esophageal sphincter tone, weight gain, the fact that the pregnant woman has a smaller functional residual capacity and is using oxygen more rapidly, they tend to desaturate much more quickly when they become apneic, and preeclampsia will aggravate a number of these factors. So how do we do invasive mechanical ventilation? Well, if you look at all the large trials of mechanical ventilation over the last 20 years, they have all either excluded pregnant patients or not specified any data on pregnant patients specifically. So we really don't know anything about ventilation in pregnancy. In terms of less conventional interventions, so nitric oxide has been used in pregnancy for hypoxemia and for pulmonary hypertension. And then an interesting report that just came out a week or two ago from the Mass Gen, where they used intermittent high-dose nitric oxide, so 160 to 200 parts per million for half an hour every 12 hours for a few days, because apparently it does have antiviral effects in addition to its beneficial vasodilatory effects. ECMO has been used since the H1N1 epidemic in 2009 in pregnant patients quite successfully, and there's still case reports with COVID. And then prone positioning sounds very difficult in pregnancy, but there are case reports and studies of arterial flow showing only a benefit in terms of blood flow during prone positioning. There's an Australian study showing that it's feasible and comfortable. And then this recent study from a few weeks ago, which actually has 2 YouTube videos linked to the study showing how to perform prone positioning in the awake pregnant patient and in the ventilated pregnant patient, with links directly to these YouTube videos. So finally, a few words about delivery of the fetus. This has already come up, but given the physiological changes, it may be considered that delivery of the pregnant woman with respiratory failure is going to be beneficial to the mother. We've already heard a suggestion from our obstetrician that maybe this is not true. This was a report from New York where 12 patients who required respiratory support, which was predominantly oxygen therapy, 6 of them underwent preterm cesarean section because of maternal respiratory distress. The gestation was 31 to 36 weeks. Only one of these was ventilated, and that patient subsequently required ongoing ventilation for almost 21 days. So not a huge benefit of the cesarean section. Among the non-intubated patients who had the cesarean section, some improved to a small degree, none got worse. So overall, there's not always an improvement. I don't think you should expect an improvement. There may be a small benefit in terms of oxygenation, but little change in compliance or PEEP requirement. We actually looked at retrospectively at a group of women who were delivered while on a ventilator. We looked at data in the 3 hours prior to delivery, 2 to 5 hours post-delivery, and 12 to 15 hours post-delivery. In addition to P to F ratio, we use the oxygenation index, which is essentially the inverse of the P to F ratio, but it also includes airway pressure. And we estimated respiratory system compliance just from tidal volumes and plateau pressures that were recorded. And there wasn't a consistent benefit. The 2 patients with the highest oxygenation indexes, so the worst lungs, actually did improve to some degree, one not a huge amount. P to F ratio, really not a great change. One woman had a dramatic improvement in compliance, but the others had very little change in compliance. Some actually got worse, and about half of them managed to reduce their PEEP by a few centimeters. So overall, if the fetus is viable and the neonatologist tells you that the fetus is at risk because of severe maternal hypoxemia, then it perhaps makes sense on obstetric causes to deliver the baby. It may or may not improve the maternal condition. Remember also that C-section is a significant physiological stress. It's an operative procedure. There are major fluid shifts. So in the patient where you're trying to really closely manage fluid, you've suddenly got a huge uterus involuting, returning fluid to the central circulation, which can also flood the lungs and cause harm. So that's it. I haven't got a list of references, but I've got a website with lots and lots of references, pregnancy related and non-pregnancy. You'll find everything that I've referred to on that website. Thank you.
Thanks so much, Dr. Lapinsky, for that. We'll go ahead and move right along to Dr. Rohan D'Souza, who'll be talking about routine and experimental medications for pregnant patients with COVID-19. So Dr. D'Souza, if you want to go ahead and share your slides.
Well, thank you very much. Can you see?
We can hear you. We can hear you. We can't see your slides right now.
It says screen sharing has failed to start.
Let's see if we can.
I tried reset. There you go.
Perfect. There we go. We can see them.
Okay, fantastic. Well, thank you very much for inviting me to speak on this this important topic. The good thing about speaking last is that the other speakers generally tend to have covered everything you've had to say. So this will be a short presentation. So the aims and objectives of this presentation essentially are to review some pharmacologic considerations in pregnant patients with COVID-19. I'll cover some routinely used medications, which, like I said, have already been discussed to some extent. I've left out the slide on analgesia and anesthesia because I realized from the talks given earlier that what we do in Canada and what is done in the rest of the world might be slightly different from what's done or recommended by the ACOG and SMFM. And it's better not to confuse the audience because the evidence is very, very limited and a lot of recommendations come from best practice or expert recommendations. I will touch upon the important topic of thromboprophylaxis. It is a very complex topic, and I will try and simplify that, and then I will talk about the experimental medications. So everything that I talk about is in 3 papers that we have published, and I will give you the references to these 3 papers. One of them is accepted in press, and the other 2 are in print. So, talking about antenatal corticosteroids, for the non-obstetrician, the important thing about this medication is that it has been shown unequivocally to reduce the risk of perinatal death, respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, the need for respiratory support, and neonatal intensive care unit admissions in babies that are born preterm. So a lot of benefits and one of the best medications that we obstetricians give. The strength of evidence for giving this medication is very strong for pregnancies between 24 weeks and 34 weeks of gestation, but the evidence still is moderate for pregnancies under 24 and above 34 weeks of pregnancy. One of the big controversies that came about earlier was, in addition to what the earlier speaker said, was that when a systematic review of 30 studies was done, looking at the use of antenatal corticosteroids or use of corticosteroids in patients with influenza, the systematic review of 30 studies showed an increased risk of mortality. However, that needs to be taken with a grain of salt. There was only 1 randomized control trial included in that systematic review, and the certainty of evidence from the observational studies that were included was deemed to be low because of the potential for confounding by indication. There isn't time to talk about the pros and cons at length, but the general recommendations are that if a person is at risk for delivering a baby between 24 weeks and 34 weeks of gestation, and there are no absolute contraindications to the use of antenatal corticosteroids, that they should be administered because the benefits are much greater than the risks. I will talk about this in the light of the recovery trial a little later. Some of the international organizations have said to exercise caution under 24 weeks and above 34 weeks. Essentially, it means that you weigh the pros and cons. A multidisciplinary team that involves an obstetrician, a maternal fetal medicine physician, and intensivist need to make a decision about whether the benefits under 24 or above 34 are indeed greater than the risks of administering this, if at all. In terms of magnesium sulfate, what non-obstetricians are quite familiar with is that it is used at all gestational ages in mothers with severe preeclampsia to prevent seizures. But what many are not aware of is the use of this medication for fetal neuroprotection. And this is, the guidelines vary from country to country and region to region, but in generally, pregnancies under 30 weeks, we do administer magnesium sulfate in order to protect the fetal brain. The controversy is twofold. There have been concerns about the risk of respiratory failure, but if you look at the literature, truly, the only increased risk is that of maternal respiratory muscle weakness, but not a risk of maternal respiratory failure. Secondly, there have been concerns about whether this medication indeed should be given or administered to people with renal impairment, and both of these considerations are important in COVID. But the general recommendation is that when indicated, magnesium sulfate should be used, like Dr. Lapinsky said. Any medication that is needed for the mother or the baby should be used, but used with caution in those with hypoxia and renal compromise. There are a number of strategies that can be put into place in order to ensure safety of the administration of this medication. We could consider modified dosage regimens. For example, consider a single bolus dose rather than continuous infusions, shorten the duration of the medication, and consider monitoring magnesium levels, especially in those with renal toxicity, the renal impairment. The third medication commonly used in obstetrics is low-dose aspirin. We do administer low-dose aspirin from around 11 to 13 weeks of gestation. Between 75 and 162 milligrams of aspirin has been shown to reduce the incidence of placentally mediated pregnancy complications, that is preeclampsia, fetal growth restriction, and preterm birth. The controversy arose when it was found that the coronavirus is bound to target cells through ACE2 receptors, and there could be an increased expression of ACE2 in patients taking ibuprofen, and therefore there were some societies like the French Society that warned against NSAIDs and low-dose aspirin early on in the pandemic. However, the World Health Organization conducted a rapid systematic review and showed no association between NSAID use and severe adverse events, increased acute healthcare utilization, decreased long-term survival, or reduced quality of life in patients with COVID-19. And therefore, the recommendation is to continue to use routine administration where indicated, because the benefits of administering low-dose aspirin outweigh the hypothetical risks. That brings me to the important topic of thromboprophylaxis. When we talk about thromboprophylaxis, we need to consider two very, very important phenomena. The first is venous thromboembolism. Now, all of us know that when all three mechanisms of the Virchow's triad are activated in severe COVID-19, and so it's not surprising that many centers have reported very high rates of deep vein thrombosis and pulmonary embolism from around the world. Now, what is surprising is that the rates of these pulmonary emboli have seemed to be, or these clots in the lungs have seemed to be quite high, even in those that are receiving thromboprophylaxis, and in fact, in those that are receiving therapeutic anticoagulation. And when you look into the depths of what really is going on, what has been recognized is that patients that have COVID-19 are not just suffering from venous thromboembolism, but from another simultaneously occurring phenomenon. What happens here is that the coronavirus attaches itself to the ACE2 receptors, and this can bring about an intense inflammatory reaction within the lungs, a localized inflammatory reaction, which has been given many names. Immunothrombosis, pulmonary intravascular coagulation. This is what is responsible for the deposition of fibrin and for the utilization of the coagulation factors driven by the cytokine storm. So two simultaneously occurring phenomena, venous thromboembolism and immunothrombosis, that are responsible for the high rates of clots in this population. Along with world experts from 5 different countries and 7 universities, we critically reviewed the literature on these thrombotic complications. And this paper is available, published by the Scandinavian Journal of Obstetrics and Gynecology. What we showed there was anticoagulants, that's heparins, low molecular weight heparin when when delivery is not imminent, over unfractionated heparin, is very effective in preventing the VTE. However, it must be remembered that these heparins can only reduce the risk of VTE and not the risk of immunothrombosis. So unnecessarily increasing the dose of anticoagulant, that is going from a prophylactic dose to a therapeutic dose of anticoagulants in the hope that the pulmonary clots will be reduced, is not evidence-based. There is a risk that unnecessarily increasing the dose of anticoagulants will actually increase bleeding complications, especially in pregnant women, without reducing the risk of clots. There could be other treatments that might be effective, like anti-cytokine therapy, antivirals, and the correction of hypoxia, but these cannot be recommended outside the setting of a clinical trial at the moment. So when decisions are being made about thromboprophylaxis, they should in pregnancy consider 5 very important elements. We cannot use a policy of one size fits all. It's definitely no doubt that thromboprophylaxis and not therapeutic doses should be used. That is kind of a consensus statement at the present moment. But one should consider disease severity. the timing of delivery in relation to the disease onset, whether this patient is being managed as an inpatient or an outpatient, does this person have any underlying comorbidities, and are there any contraindications to the use of anticoagulation? So it is a complex decision-making process, which we have tried and simplified in this very busy table. So I'm not going to go over this at length, but what I'd like you to see is that decisions on whether a person and what kind of anticoagulation a person should receive should depend on whether they're isolating at home. And for those isolating at home, whether the pregnancy was low risk and the risk for venous thromboembolism is deemed to be low, whether they've got risk factors for VTE and are currently not receiving thromboprophylaxis, whether they are receiving thromboprophylaxis and isolating at home. If in hospital, whether they are admitted for a non-COVID related reason like breaking their waters or a small antepartum hemorrhage, or whether they are admitted for COVID related problems like a pneumonia requiring supplementary oxygen but not ventilation, or whether they are admitted as an inpatient with pneumonia and requiring mechanical ventilation. Again, the decisions are based on whether they're in the antepartum period, immediately close to delivery, postpartum while in hospital, and postpartum upon discharge. So this graph will still require consultation with a multidisciplinary team, but will provide a lot of guidance to people trying to anticoagulate pregnant patients with COVID-19. My last part of my presentation is on experimental drugs. We know that there is now strong evidence for the use of corticosteroids thanks to the recovery trial. This trial showed that the difference was most pronounced in those on mechanical ventilation or needing oxygen, but there were only 6 pregnant patients in the interim analysis among the thousands that were recruited. Despite that, the National Institutes for Health, given the evidence for corticosteroids and the safety in pregnant patients, has said that corticosteroids may be administered in pregnant patients needing oxygen or mechanical ventilation. With regard to the other experimental medications, I saw one of these questions asking, what do we do with pregnant women? Do we give it, do we not? The problem is, like Dr. Stephen Lapinsky showed with his mechanical ventilation slide, most studies seem to want to exclude pregnant women. And that really doesn't benefit anybody because the evidence remains lacking. We tend to extrapolate information from non-pregnant populations, and that doesn't benefit the population that we're looking after. So there is a need to continue to recruit patients into ongoing trials. With regards to hydroxychloroquine, lopinavir, ritonavir, and remdesivir, we know that although they are safe during pregnancy and lactation within the context of clinical trials, the data from non-pregnant populations have shown no benefit. So it's difficult to say whether the pregnant patient should continue to be recruited into trials using these medications. However, there are a number of other drug trials that are ongoing. And the information on whether they might be effective in pregnancy and lactation is unknown, but the drugs might in themselves be quite safe for use in pregnancy and lactation. It's difficult to keep track of what is safe in pregnancy and lactation, and therefore, in another publication, which is accepted by the Journal of Ultrasound and Obstetrics and Gynecology and will be in print very shortly, what we tried to do was to create a table like this, which color codes the safety of various medications that can be tried in pregnancy in the setting of a clinical trial or with close monitoring. What we've done here is we've talked about the pregnancy risk, and the pregnancy risk relates to 2 different risks. One is teratogenicity, that is the structural abnormalities in a fetus, and other toxicities like preterm birth or growth restriction or things that are not structurally related directly or non-teratogenic. And then we have looked at the risks in breastfeeding. We have put texts within each of these boxes. I've just put a color-coded table for now. But essentially what you can see is in the breastfeeding period, most drugs are either, there's limited data, but they're probably compatible, or they are compatible with the benefits outweighing the risks. There are a few in which risks versus benefits need to be considered and some in which human data is not available. But even within pregnancy, except for a few that are absolutely contraindicated in pregnancy, the others, there may be limited data, but they're not contraindicated, which means pregnant women can be included in these in trials and these studies. So the data, unfortunately, I don't have answers to questions on whether this is safe and this is not safe, but what we for use in pregnancy and COVID. But what we do know is that if we do have pregnant patients that are sick, corticosteroids can be used, and some other experimental drugs may be safely tried under the purview of a clinical trial. So all of the information that I have just shared is within these 3 publications: Pregnancy and COVID Pharmacologic Considerations, which I'm happy to send the organizers a PDF copy of as soon as it is made available to me the next couple of days. This paper on the thrombotic complications and recommendations for thromboprophylaxis in pregnant patients with COVID-19, and our moral imperative to try and convince trialists to include pregnant patients and encourage pregnant patients with COVID to enroll in trials with COVID-19. With that, I'd like to acknowledge everybody that made this presentation possible. I'm happy to take any questions.
Thanks so much, Dr. D'Souza. I think the only remnant question from the chat was really any specific recommendations that you or any of the others would have regarding convalescent plasma or remdesivir for COVID-19 patients that also happen to be pregnant. And, you know, given the lack of data, it would be nice to hear what you're doing at your center.
So what we're doing at our center is we are preventing COVID from happening. And so we've really had no patients, very, very few patients come in. We've had 22 in all of Toronto, with most of them having very mild illness. Only 2 have seen Dr. Lapinsky. I don't know. Only 2 of them have had to see Dr. Lapinsky, and he sent them packing quite quickly. So the data for remdesivir is probably not very impressive. Let's put it that way. And I don't know whether there is any point in trying something that has not worked at all in the non-pregnant population and subjecting pregnant women to trials, ongoing trials that have that. Convalescent plasma is another story. It is something that can safely be used. I'm not aware of convincing data to say that it's not effective, and therefore I don't know what the others feel, but I think pregnant women could still be recruited into trials. I don't think there is any drug that we have strong evidence in favor of except for corticosteroids, and therefore if anybody claims to say that somebody should or should not receive something, that is I don't know where that evidence is coming from, but what we should be encouraging is for the drugs that are known to be safe, if it's under a clinical trial, then pregnant women should be recruited. But that's my take on it.
Sheetal,
Thanks.
I know I told you that, you know, I won't be speaking, but I have a very niche question for Rohan. So, and I don't know if there's an answer to this, right? So I preface it with this, but so, you know, we know that in non-pregnant patients who are severely sick with COVID, steroids are recommended, broadly speaking, and then who are not too sick, you're not recommending steroids early on, right? Broadly. And then for patients who are pregnant, you said when you normally would use steroids, please go ahead and use them. So what about pregnant patients who are not severely sick with COVID? They have COVID, but they're not severely sick, but they're pregnant. So that very narrow population, do you think steroids, would you consider them, not consider them?
So, I mean, so if a person is not very severely sick, let's put it that way, do they really need treatment more than just observation and monitoring is the question. So what the evidence we have, sometimes we have a tendency to extrapolate, and that's what I've seen a lot with the thromboprophylaxis literature. So, but in answer to your question, the evidence has only been shown in those that are requiring oxygen or mechanically ventilated. It's very, very clear. So, and that is in the non-pregnant population. So it seems like if there was a pregnant woman that needed oxygen or was mechanically ventilated, this should be tried because this might be of benefit. And I'm happy for Dr. Stephen Lapinsky to chip in as well. But for the others that don't even require oxygenation, why are we giving them corticosteroids? I mean, I don't think I would, or I don't think the evidence points towards just giving it to them so that, I don't know what we're looking for, what improvement we'd be looking for.
So you're saying treat the patient, not yourself. I like that.
Yes, yes.
I would agree 100% with Rohan. I mean, it's inflammation, presumably, that you're treating with the steroids. And if there isn't a massive inflammatory response in the lungs, you're not going to benefit. But thinking back, what I didn't cover in my talk is the importance of monitoring these patients and identifying the ones who are deteriorating. You know, on an obstetric ward, they're monitoring the baby, they're doing the blood pressure, they're not really doing the SATs that closely, but keeping a very close eye on the saturation, oxygen saturation, and make sure that you're aware if there's any change immediately.
Thank you both for that. Dr. D'Souza, lovely shout out to the good job done by the Torontonians and the Canadians, and Dr. Lapinsky as well. But certainly we caught that there, Dr. D'Souza. So, all right, well, I think we'll close out. I don't think there are any remnant questions, but thank you so much to Drs. Folk, Shaker, Lapinsky, and D'Souza for joining us tonight and sharing your knowledge and experience. It was a great session. Thanks to all of you guys for joining us. And then certainly please remember to fill out your feedback survey, and hopefully you'll continue to join the sessions. Thanks, everyone. Have a good night.
Bye.